Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. This is part of our series on sleep and mental health. The content here is for educational purposes only and does not constitute medical advice, diagnosis, or a prescription. Clinical decisions should be based on individual patient assessment and established professional guidelines. Before Z drugs, before melatonin agonists, before the modern push toward precision sleep medicine, there were benzodiazepines. For decades, benzodiazepines were the backbone of pharmacologic sleep treatment, especially in psychiatry. They did not just help patients sleep. They reduced anxiety, muscle tension, and emotional distress. And for a long time, they felt like the right answer. Benzos work by enhancing the effect of GABA, the brain's primary inhibitory neurotransmitter. They bind to the GABA-A receptor and increase the frequency of chloride channel opening, globally suppressing central nervous system activity. For sleep, this produces sedation, muscle relaxation, and suppresses anxiety, but not physiologic sleep. The most commonly used benzodiazepines for insomnia include temazepam, lorazepam, clonazepam, and historically diazepam. Temazepam is the classic sleep benzo. It is typically dosed between 7.5 to 30 milligrams at bedtime. It has an intermediate half-life of about 8 to 15 hours, making it effective for sleep onset and maintenance, but also increasing the risk of next-day sedation, especially in older adults. Lorazepam, dosed at 0.5 milligrams to 2 milligrams at bedtime, is shorter acting and often used when insomnia is tightly linked to acute anxiety. However, its relatively rapid onset reinforces medication-dependent sleep and increases rebound insomnia when discontinued. Clonazepam, dosed at 0.25 milligrams to 1 milligram at night, is longer acting and sometimes used when insomnia overlaps with panic, parasomnias, or movement disorders. But its long half-life, up to 40 hours, makes accumulation, daytime sedation, and cognitive impairment real concerns. Diazepam, once widely prescribed, has an extremely long half-life and active metabolites. While effective for anxiety, it is generally a poor choice for insomnia due to next-day impairment and high dependence risk. From a sleep architecture standpoint, benzodiazepines reduce sleep latency and increase total sleep time, but they suppress slow-wave sleep and REM. The sleep they produce is lighter, less restorative, and more fragmented over time. Tolerance develops predictably. The sedative effect fades before the anxiolytic effect, encouraging dose escalation or polypharmacy. Dependence can develop even at therapeutic doses, particularly with nightly use beyond a few weeks. Withdrawal is not benign. Abrupt discontinuation can cause rebound insomnia, anxiety, autonomic hyperarousal, tremor, and in severe cases, seizures. From the brain's perspective, benzos do not teach sleep. They replace it. Psychiatrically, this matters. Benzos can temporarily reduce distress, but long-term use worsens emotional regulation, impairs memory consolidation, and increases fall risk, motor vehicle accidents, and cognitive decline, especially in older adults. They also blunt the effectiveness of psychotherapy by dampening learning and memory formation. This is why modern guidelines are clear. Benzos may have a role in short-term, carefully selective cases like acute insomnia, severe situational distress, or time-limited bridging, but they are not a solution for chronic insomnia. The core problem is not that benzodiazepines are ineffective. It's that they treat insomnia as a volume problem rather than a regulation problem. They suppress wakefulness instead of retraining the sleep-wake system. And when the medication stops, the underlying insomnia is often stronger than before. This realization marked a turning point in sleep medicine, one that pushed the field toward treatments that work with sleep biology instead of overriding it. In the next episode, we will talk about the 3Z drugs. Thank you for listening. If you found this episode useful, please share it with colleagues across disciplines. Till next time.